So, good evening, everyone. It gives me an immense pleasure to welcome you to the first webinar of VERTICON, which is an exclusive initiative of American Institute of Balance India, fondly known as AIB India Academy. VERTICON is a three-part webinar series wherein we are conducting the first program today, followed by the one on 24th of Jan 2026 and 7th March 2026 again. We will be having one international speakers and three national speakers having in this program, and we look forward to carry our goal and objective to spread more awareness and education in the field of vestibular and balance disorders. As we start the sessions today, we have an excellent faculty today, along with Dr. Prashant Kevle, sir, Dr. Kavita, and Dr. Stephen Springs joining right from US for his lecture, followed by my lecture, provided if we don't overshoot the time. And with this, we will start today's session, and I will hand it over to Mr. Pinakin Munshi, my Vice President for AIB India, for further proceedings. Thank you.
Thank you, Dr. Neha Shrivastava, and good evening to you all from India. Those of you who are joining from Middle East or other parts of the world, good afternoon, good morning to you. So our first speaker for the evening is Dr. Prashant Kevle. Dr. Prashant Kevle is an accomplished ENT surgeon with over 21 years of experience. He is MS ENT, has a diploma in otorhinolaryngology from the College of Physicians and Surgeons, and an MBBS from a leading Mumbai institution. He was awarded the first rank in MS ENT for the state of Maharashtra. Currently, he heads ENT department at 2 major hospitals and is a consultant at multiple reputed centers across Mumbai. He is highly accomplished in cochlear implants, advanced endoscopic surgeries for sinus, sleep apnea, head and neck cancers, thyroid and parotid glands, and in vertigo management. He has published several research papers on ENT, allergy, anosmia, and trauma-related ear injuries. An active international and national speaker, he has conducted numerous workshops, including VERTICON's temporal bone workshop, and contributed extensively to community health and disaster care. I invite Dr. Prashant Kevle to present his topic for the day. Over to you, Doctor.
Thank you, Pinkin, for the kind words. And I should thank AIB to give me the platform. Good evening, all from Mumbai. And I think my screen is just sharing. Sorry. Yeah. So I think, am I audible and visible?
Yes, sir.
Yes. So today's topic is Meniere's disease. We all know Meniere's disease is a triad of tinnitus, earfulness, and dizziness. Is it curable? No. Meniere's disease is not curable. Only we have to find out the patient is in which state, and we can make his life better by managing his further progression of disease. So let us dive into the Meniere's disease with this small note. So previously it was thought that it is from the brain, but at 1861, a French physicist, Prosper Meniere, he theorized and said that this is tinnitus, vertigo, and decreased hearing is from the inner ear and not from the brain. After that, 2015, so many societies come together, Baroness Society, European Society, American Society, and all these, they came up with some guidelines, and they have classified Meniere's into 2 types. That is definite Meniere's disease and probable Meniere's disease. So let us look at the definition by words. What is definite Meniere's disease and what is probable Meniere's disease? So it says that to make it definite Meniere's disease, there should be 2 or more episodes of spontaneous vertigo, which may last from 20 minutes to 12 hours, with the audiometry evidence of low to medium frequency SN loss in one ear as compared to the other ear, during the episode and after the episode or after the episode. And along with that, fluctuating oral symptoms like decreased hearing, tinnitus, and oral fullness. These 3 criteria, if the person is following, he is having definite Meniere's disease and not better accounted by any other vestibular diagnosis. So let us have discussion on this. When we say that affected ear, we look at the low frequency SN loss, and that should be at least more than 30 decibel as compared to other ear. So we look at the bone conduction. And it is in the lower frequency, say between 500 to 2000 hertz. So this is what is the main criteria we look for, and then we know that slowly the disease is progressing and there is a sensory neural hearing loss occurring because of the endolymphatic hydrops. So let's go ahead, and the tinnitus, it may be initially fluctuating, but as the disease progress, because the damage to the inner ear is continuous, it will be a continuous tinnitus due to SN loss. Dizziness may remain longer as the episode will go on increasing, and audiometric evidences will show that in between episode there is an improvement in hearing. Some patient can experience vertigo lasting for seconds to minutes, and it can be triggered by high intensity sound that is called Tullio phenomena. Why? Because the middle ear is damaged. There is the inner ear is damaged, and when there is a high frequency impact onto the inner ear, it can lead to disruption of the particles into the utricle, and then that can lead to the sudden episode of vertigo and even fall. And that is what is Tullio phenomena. So, and what is probable Meniere's? So, in that, there may not be the hearing loss which is there as per the audiometry, but there are 2 or more episodes of vertigo, which is more than 20 minutes to 24 hours can be considered, and there is fluctuating oral symptoms as hearing, tinnitus, fullness. Now, why this is probable? Because in this, maybe these are early patients where they are just started with Meniere's disease and there is no SN loss. So, audiometry may not prove that there is a sensory neural component, but patient may experience these vertigo episodes and there could be fluctuating hearing, tinnitus, and fullness. So, this is called probable Meniere's, and as the disease progresses, probably the patient will have something evidence onto the audiometry as well. So this is what is Meniere's disease. So we know that it is a type of peripheral vertigo and lasting for hours. In the Meniere's disease, there is an endolymphatic hydrops. There is a fluid into the endolymph, which is in the inner ear. And when there is a blockage or there is a hyperproduction, there will be increase into the endolymphatic pressure. And then that leads to the vestibular and the cochlear symptom and the vestibular symptom as well. So we go to the etiology. What are the causes? It could be the vascular etiology, could be the viral etiology, could be immunological. There may be increased production of the endolymph, or there could be decreased absorption. All the is all postulated. Now we have migraine Meniere's complex disease, and sometimes it is idiopathic. So looking at the etiology, we know that we have no definite answer why it is happening. And therefore, there is no definitive treatment to cure this disease. But now when you know that there is increased production or decreased absorption, we can have some other solutions so as to modulate these kind of phenomena. So we have to differentiate it from autoimmune ear disease because it is a progressive hearing loss. We have to rule out whether it is autoimmune ear disease. Vestibular migraine, I told you it is the migraine Meniere's complex sometime we get. And sometimes there could be endolymphatic sac tumor. Vestibular paroxysmia, some people will have even vertigo for a few seconds, but vestibular paroxysmia will have more than 2, 3, 4 episodes in a day as compared to Meniere's. Meniere's people will have only 1 episode in a day, and maybe on the other day, second day, third day, that episode will be there. But vestibular paroxysmia will have multiple episodes. Now, transient ischemic attack, why it is having a differential diagnosis? Because patients sometimes will not come to you when there is an active episode going on. And he will explain to you as an episode of imbalance, fall, dizziness for some time. And it recovered by its own. So as a physician, we may think that it could be the transient ischemic attack. And yes, we have to look at the other danger sign to see that whether that was a transient ischemic attack or the Meniere's. So this is again a differential diagnosis. And as the disease progresses, we'll have some definite evidences. But you should do MRI if there is a doubt and rule out whether there is no transient ischemic attack. So what are the diagnostic tests? VNG, video nystagmography, is good state test because as the disease progresses, you may get a labyrinthine failure and you may get the caloric test negative or on that side. Pure tone audiometry. As the disease progresses, there will be an increasing sensory neural hearing loss, and that will be seen very clearly onto the audiometry. So if the patient is coming in early stages, you ask the patient to do the audiometry. And if it is not showing any changes, you ask the patient to repeat the audiometry every 6 months or 1 year to understand that change in pattern. Sometimes when the patient is having early Meniere's, there could be conductive hearing loss. Why conductive? Because there is an endolymphatic fluid pressure increasing, and that will impinge onto the oval window and will lead to decreased mobility of the stapes, and that leads to conductive hearing loss. So audiometry is something which is very much important, and in these patients, we have to repeat the audiometry at several occasions. MRI cochlea, it shows sometimes the gadolinium induced and there may be some bubbles in the cochlea which are seen, but not that very evident. Bera, yes, sometimes Bera will pick up very high frequency into the Bera and that may indicate to the cochlear pathology. Glycerol test nowadays, I don't think it's done, but it is the test which will give that at least a diagnosis of Meniere's disease. ECOG is again a test which will give an indication that which ear is affected and accordingly we can go for that treatment. So I told you as it is a progressive disease and Meniere's disease patient will be coming to you at different stages. So if the patient comes in early stage, he will have episodic tinnitus followed by decreased hearing and then there will be vertigo spell. And in this patient will have conductive hearing loss during the episode. As the disease progresses, he may have low to mid frequency sensorineural hearing loss. As the disease progresses, as the episode becomes multiple, patient comes in a mid stage where now the tinnitus is not episodic, it is continuous because there is a cochlear loss. There is sensorineural hearing loss. Again, the hearing will be decreased, but it will further decrease when the episode of vertigo will come. And that patient will come to know that my hearing is down, but when the vertigo starts, it again goes down. My tinnitus, again, it gets roaring tinnitus. And these are the episodes these patient will tell when they are in mid stage. And now the patient is having a lot of fear and anxiety, irritability, because that episodes make them so unstable that they will be helpless and they have to restrict whatever they are doing, they have to leave it because the episodes are severe. And there could be sound distortion because of cochlear problem. In the late stage, what happened? The tinnitus will increase to roaring tinnitus. And now patient has lost his hearing. So it is a dead ear for the patient. Will the patient have vertigo episodes? No. Now the labyrinth is also damaged. And therefore patient will have a chronic instability because of vestibulopathy. So these patients will now say that there is a roaring tinnitus. Sometimes the episodes are more, sometimes the imbalance is more, but the chronic instability is there. And now it is affecting day-to-day life. So these are the patients who are in a late stage. There may not be any episodes of severe vertigo in between. Sound distortion will be there. Increased sensitivity will be there. Loss of depth and spatial orientation because of vestibulopathy. Sudden drop attacks because the labyrinth is damaged and therefore there could be destruction of the macula and can lead to the sudden drop attack, but there will not be any loss of consciousness. So all these are features of late stage. Now, why it is important to know these stages? Because accordingly we can do the treatment. So let us have one example. This patient has come in acute condition. We can see that there is a right beating nystagmus. When the episode was going on, that time the patient visited and I could notice that it is right side, right beating nystagmus we can see. And when the patient looked to the left, there is no nystagmus. So there is no nystagmus when they look to the left. Now, when I do head impulse test, first I am asking for her to stabilize her eyes. And then I'm giving a thrust to right. There is corrective saccades. So that means the left side labyrinth is not performing and not able to fixate the vision. When I ask her to do Attenberger test, she is not able to maintain and she is falling on the left side. So that indicates that left labyrinth is damaged. When she is able to walk with open eyes, the moment I ask her to close her eyes, So moment she like try to walk, she is going to fall on the left side. So because now in this case, why there was right beating labyrinth? Because left labyrinth was not performing and the right labyrinth was the normal labyrinth, and therefore we will have right beating nystagmus. So these are the features, and the patient episode was only of 2 hours. So I know that this is what is the Meniere's, and patient is having left Meniere's, left labyrinth affected. So accordingly, we should be able to now do the management. In the acute episode, what can be done? Ask the patient once the alarm rings, get to the safe and secure place. Do not try to cross the road. Do not try to be on that any vehicle or something like that that can endanger their life. So that is the first advice to the patient. They should go to the safe and secure place, sit down wherever they are and ask for the help. That episode may last for a few minutes to few hours and you don't know, but that you ask the patient to be safe and secure place. Labyrinthine sedatives can be given, but they may not work. And once the episode gets over, ask the patient to have a sleep of at least few hours because they have post this thing, they have dizziness and again bit instability. So this is for the acute episode management. Now, if the patient is coming in early stage, say few only episodes are there, ask the patient to reduce the salt into their diet. Steroids can be given, diuretics can be given, potassium syrup can be given to increase the potassium. So when the potassium increases, the sodium goes down. So you can ask the patient as a dietary measure, you can ask them to have one banana or coconut water every day. So that is their routine and that will help them to increase the potassium and reduce the sodium. So these advice can be given in early stages patients. Antacid because they have a lot of vomiting episodes. Beta histine is said, some people are doing the trial, they are saying the beta histine is working and they are giving it around 100 to 200 milligram per day. But yes, we need to look at the evidences. Though it is, there is a concept that there is a vasodilatation and that will take away the endolymphatic pressure and it will help. But yes, it to be proven. Intratympanic steroids will be better because as there is a disease progression, there will be sensory neural hearing loss. So this will be hearing preserving and even it will be helping the sensory neural component to be into control. Intratympanic gentamicin, where you want to destroy the labyrinth, and that can be done. But then at this, the patient may be having the late stages, somewhere there is a SN loss, and there you may have to you may go ahead and damage by giving intratympanic gentamicin. In the late stages, when the patient is having, say, bone conduction at around 40-50 decibel, you can still conserve that and you can go ahead for endolymphatic sac decompression. In this, we'll see a clip how to do the endolymphatic sac decompression. And if it is dead ear, go ahead and do the labyrinthectomy because the patient will get stabilized after 1.5 months of your rehabilitation, and then there are no episodes of imbalance. So now let us see some cases. So this patient, I'm asking him how's his episodes, and he's saying that the episodes were for a few hours since approximately say 1.5 years. And then every time he's having a lot of trouble, he's on multiple medication.
किती वेळ अप्रॉक्सिमेट दीड तास होते. दीड तास तुला ते सगळं फिरतोच होतं कोणतो हा कंटिन्यू आणि मग थांबतो. हो मग दीड तासाने नॉर्मल झालो पण जे कान गच्च किंवा कानामध्ये हलकी घंटी वाजल्यासारखं त्यावेळेस आला होता हा ते चालू होतं कंटिन्यू पण चक्कर माझी दीड तासात.
So he is saying that 1.5 hours the episode was there and then the tinnitus still continue. After 2-3 days again he had the episode. And now the episodes are increasing. At least in week he is getting 1 or 2 episodes. So this is what is his complaint. So for this patient, we tried giving steroids and even diuretics. Even Dimox was given sometime, but his episodes were not improving. But his hearing was not that bad. And therefore, we decided to do endolymphatic sac decompression. So in this, we open a mastoid. Now the island is created. And this is the sigmoid sinus. We are going to depress the sigmoid sinus. This is a posterior canal and this is a Donaldson line. So we'll be finding the sac somewhere from here to this side. So normally the sac is at around this where the Donaldson line, and we have to search the sac from here. But if we are not getting the sac here, we have to further remove this dura, the middle cranial fossa bone, and we have to search the sac further ahead. So as we progress, we are searching from here, but I'm not finding the sac. But in this case now, we can see this fan-shaped sac, which is seen. Once we are seeing the sac, we can open the sac with a sickle knife, and we can see that there are two layers, and make sure that we are in the sac. And once we are sure in the sac, we want to keep a silastic sheet implant. So make it a T-shaped kind of silastic. So the long arm will be outside, and the upper arm will be inside the cut margin of the sac. So now here we are trying to put the silastic sheet into the where the sac is open. So the arm is going inside the endolymphatic sac, and one arm is outside. So this is the patient's audiogram, and this is a VNG report, which is showing the left-sided hypofunctioning. And see the audiogram. So there is SN loss. As I told you, it is a low to mid frequency sensory loss. But the loss was around 40, and therefore it was still hearing, and therefore we did for this patient. And see the look. The patient is very much happy after the surgery, and now the episodes are not there. So so this is around 3 to 4 months follow-up now. The patient is having absolutely no symptoms of vertigo. They are decreased. So he is saying even his tinnitus has gone down. It is 10%, and the hearfulness is also better. So this is what this patient of endolymphatic hydrops. Now this patient, we operated around 1.5 years back. Patient was having dead ear. He was in late stage, but he was having chronic instability. So we did labyrinthectomy, and after labyrinthectomy, the patient improved a lot. Now there are no episodes, and now even his balance is good.
तुला आता काय त्रास कसा असेल असं असं पण मला बॅलन्स नाही सांभाळायचा होता असं असं चक्कर येत जास्त केलं चक्कर येते अशी चक्कर येत घेतल्या पण आता काय कॅमेरामध्ये बघत राहा वन साइड.
So we are doing his head impulse. See, he's operated for the left side, so the head impulse is also good. When I'm asking the patient to do, so this is 1.5 year post-op, and see his balance. So patients now, though he's not having the hearing, but his main problem of instability is now not there. And now he is happy that at least he is able to manage everything, and one side hearing is there. So we should not hesitate to even go ahead for labyrinthectomy, because as per the stages, we have to give treatment. If the patient is coming in early stage, try and save his hearing, try and give steroids, whatever works for the patient. If the episodes are getting controlled, if his cochlea is not getting further damage, I'm happy to give. But if the cochlear damage is still going on, if there is, we have to go ahead for at least endolymphatic sac decompression. And if it is a dead ear, why the poor fellow should suffer from this instability? We can go ahead and do labyrinthectomy. After labyrinthectomy, give the patient vigorous vestibular rehabilitation for 1.5 months, 2 months. They will be better. So I feel this is management, what I follow in my practice, and I think it should be helpful. So thank you for all your kind attention. And I guess if any questions are there, we'll see at the last.
So thank you for delivering an enlightening session. Again, your expertise and perspective will help further add to the knowledge of Meniere's disease. And we request you, sir, to please remain with us for the panel discussion. I think it will take another 45 minutes to 1 hour, so please join us back.
Sure.
And there are questions, of course, there are questions which have already started coming up, and we request our audience to please put your questions in Q&A so that we can answer at the last. Thank you so
Definitely.
much.
Thank
Over to Pinakin, sir. Yeah.
Yeah. Thank you, Dr. Prashant Kirve. Our next speaker for the evening is Dr. Kavita Rohit. Dr. Kavita is a MS ENT specialist with extensive experience in vertigo, giddiness, and balance disorders. She heads a dedicated, well-equipped vertigo clinic at Lakshmi Nursing Home, Mulund, and also consults at Shushruth Hospital, Chembur. With over 10 years of clinical expertise, she has successfully treated numerous patients, helping them regain balance and quality of life. She has also authored numerous research papers in reputed national and international journals. Dr. Kavita is committed to advancing patient care and contributing to medical knowledge in the field of neurootology. I now invite Dr. Kavita to take stage to discuss her topic for the evening. Over to you, Doctor.
Thank you so much. I'll just start sharing the screen. Okay, shall we go ahead? So I'm going to begin this presentation by a case presentation where we hear the patient's history. Okay. Do you feel that everything's done? I'm having weakness for the last 3 weeks. Okay. Do you feel that everything in front of your eyes is moving? Like, will the furniture move right to left, or do you think you are moving from the inside? I feel I'm speaking. Okay. And how long will it last? Few hours. Anything you feel is triggering this giddiness? Any head position? What do you think is triggering this giddiness? Okay. Okay. Do you have any ear complaints? Do you hear less of is that ringing sensitivity? Do you also have any headache? Okay. Okay. How many episodes of this giddiness do you say you have in a week? 3 or 4. Okay. Is there any loss of balance? Any imbalance in walking? Okay. Any blood pressure, diabetes, asthma? Or... So to conclude, this patient says that he's been having the non-rotatory type of giddiness for the last 3 years, which is lasting for a few hours. More often it is self-limiting, and sometimes he takes medications like beta-histine for it. He has numerous triggers, which includes being having lack of sleep, being on an empty stomach. He has a history of headache, which has been migrainous in nature, again, which has had triggers, and there has been no oral complaints whatsoever. So just based on the history, one would think that this patient is probably a case of migraine. Let us see what happens during examination. So his Romberg's tandem and escalating sensory denial were fine. But the moment he starts doing the high stepping gait test, we can see that even before breaking into the 15-20 steps, he has already started turning towards the left. And you can see he is making a 360-degree turn to the left. Now, during his head impulse test, you can see that the head impulse to the left is positive. There is a saccadic connection, whereas on the right, it is normal. Once again, the head impulse to the left shows that it is positive. Now, the moment we've used a VNG goggle on him, there is a right beating spontaneous nystagmus, which is abolished by fixation. We can see the nystagmus in progress at the moment. So it is important to note here that with the naked eye, during clinical examination, we were not able to appreciate this nystagmus. There was no nystagmus even on gaze test for this patient. So in conclusion, even though the history was typical of migraine, the examination revealed that there has been some amount of left labyrinthine dysfunction. His pure tone audiogram is normal, and hence he would be concluded to have a case of migraine along with left-sided neuritis in a state of recovery. Now, his treatment will involve not only the use of anti-migraines, but also rehabilitation therapy. Coming to our next case.
कौन से साइड में आपको कितना टाइम के लिए बताओ तो सब कुछ आमने सामने दिखता होगा सब कुछ आप देख रहे ना बनता है और वापस सर सीधा करेंगे तो ठीक हो जाता है कितना टाइम से करते हो आपको ठीक
As you can see, this patient was extremely reluctant. She had very severe giddiness. She was not able to move her head. She just wanted to keep her head straight. She was not ready to speak up even. Now, her giddiness, she says, is the rotated type of giddiness on changing her head position, which is lasting for over 30 minutes. This has been going on for the last 6 months, and she's had multiple attempts with the maneuvers, but they would give her temporary relief and she would come back to square one. On examination, her Romberg's tandem, high stepping, head impulse, cerebral, and oculomotor tests were normal. She also had an MRI report with her which said that there is slight abutment of the ICA loop on the 7th and 8th cranial nerve complex, but there was no indentation. Now, this is the left Dix Hallpikes. She was very uncooperative, so we've not used a VNG goggle on her.
Madam.
You can appreciate the geotrophic nystagmus beating towards the lower ear.
Madam.
So the intensity of nystagmus has been almost the same for over a period of 12 minutes, which is a very long duration for a case of BPPV. So this is an almost a 9 to 12 minute long nystagmus in the Dix Hallpike position. We did an Eplise for her, and post Eplise, you can see that she continues to have the same intensity of the nystagmus and similar duration. Now, this is when you suspect that probably the particles are in the short arm. So we then did multiple attempts of quick liberatory maneuver over the next 3 days. In fact, the patient was admitted because she was in so much distress. And finally, after 3 days, she was vertigo free. Now, many times BPPV is camouflaging inner ear pathology. What happens is when a case of BPPV comes to us or assumed BPPV comes to us, we are happy because they are relatively easy to diagnose, they are easy to treat. The maneuver is extremely effective, recurrence rates are less, the treatment works as a miracle, there are no medications, and it is an OPD-based procedure. Now, in our third case, we had a 59-year-old female who complained of spinning sensation while turning her head since the last 6 months. Duration was less than a minute. There were 2 to 5 episodes every week. They were on and off. She had unbearable tinnitus in the right ear, and she had gradual progressive hearing loss, which has been constant in the right ear for over the last 6 months. Her clinical examinations were all normal. Coming to supine roll on the right side. The above is a video of the supine roll to the right, which is showing us a right beating nystagmus. And below that, for your reference, I have put the supine roll to the left, which is showing us a left beating nystagmus. As you can see, the right is a much stronger nystagmus. And hence, she was concluded to have right lateral semicircular canal, BPPV, canalolithiasis. Okay. So the barbecue maneuver was done. The patient again returned after a week with similar right lateral semicircular BPPV. A PTA was repeated. She had similar hearing loss like she had 5 years ago. Just because she gave us a history of course, her VNG test was done and all the VNG tests were normal. Now, she was suspicious of Meniere's just because she had those on and off episodes of tinnitus along with the hearing loss. However, the hearing loss was constant. So we started her on Dimox 250 milligrams along with some amount of clonazepam and escitalopram. Now, a 6-month follow-up, there has been no giddiness and her hearing has also improved. And there has not been any episodes of positional vertigo either. Now, an interesting thing in this is that periodic hydrops leads to destruction of your sacula and the utricular macula. Now, this leads to repeated release of otoconial particles. These otoconial particles, in fact, cause recurrent BPPVs. Sometimes the periodic hydrops can cause partial or collapse with adhesions in the labyrinth. This in turn leads to partial obstruction and your maneuvers are less effective when you do it in cases of Meniere's. Now, vice versa, BPPV leads to floating particles, which then in turn will lead to obstruction of the endolymphatic flow, which then lead to hydrops. In our next case, we have a 37-year-old female who complained of giddiness with change in position, again lasting for a few seconds, just for the last 3 days. There was no other significant history. On her first visit, her left posterior semicircular canal had a BPPV and we had done the Eplys for her. After 48 hours, there was no giddiness. Her VNG was normal, her PTA was normal. Her second visit was after 3 weeks. Again, she had similar complaint. Again, it was a left posterior semicircular canal BPPV on Tixolpide. Eplys was once again repeated. And in the third visit after 2 months, the same thing happened. So in such cases, it is always better to do an MRI just to make sure that you're not dealing with anything else. And her MRI revealed a 1.2 into 1 into 0.9 centimeter acoustic neuroma at the CP ankle. Now, just because it was an early detection, we had the option of hearing preservation and the retrosigmoid approach for her. Now, in this case, she did not have any history of tinnitus or hearing loss. So in conclusion, I'd like to say that any inner ear pathology which causes dislodgement of the otoconia without hampering the function of canals can lead to coexistence of different pathologies. Recurrent BPPV must always be treated with a high index of suspicion. The effectiveness of your treatment is only when all the underlying pathologies are addressed, and all patients must undergo the entire battery of clinical examination. A high index of suspicion will lead to better diagnosis for our patients. Thank you.
Thank you, Dr. Kavita, for a great session, and especially you told about the overlapping of the symptoms, basically when it comes to BPPV, because it can be seen in any of the conditions. So it was a great lecture, especially of the explanation of the Meniere's disease also. So we are just continuing the Meniere's disease overlap as of now from Dr. Kevle and your lecture. I would request you to please sit back and wait for our panel discussion, and maybe after another half an hour or so. Yes, thank you so much.
Thank you, Dr. Neha. Our next speaker for the evening will be Dr. Stephen Spinks. Before we go to that, we'll have a short video, on AIB Academy. So I request. Thank you. So moving on to the next program. Now we have our next speaker for the evening. That is Dr. Steven Spinks from USA. Dr. Spinks is a doctor of physical therapy. He is a board-certified orthopedic specialist and a fellow of the American Academy of Orthopedic Manual Physical Therapist from the Upstream Rehab Institute. He is currently pursuing a PhD with research focused on cervical spine considerations related to dizziness and concussions. He serves in key leadership roles within the state physical therapy associations and has been teaching vestibular and concussion rehabilitation courses since 2016. Dr. Spinks is an assistant professor at Gannon University, specializing in musculoskeletal and advanced practice coursework with strong scholarly interests in vestibular concussions and orthopedic manual therapy. I hand over the stage to Dr. Spinks. Over to you, Doctor.
All right, thank you very much. Appreciate it. Thank you again for the opportunity to be here. Can you see my screen? We're good? All right, so I'm going to be talking about cervicogenic dizziness and how this plays a role in our differential diagnosis for patients who are coming in with dizziness where some of our neurodiagnostic testing is inconclusive. This is just some objectives that I wanted to talk about, specifically techniques in differential diagnostics, both from a subjective and an objective lens. Disclosures, I teach for the American Institute of Balance and have since 2016. I'm not receiving any financial interest to disclose for this. So Furman and Cass in the 1950s looked at cervicogenic dizziness, and it used to be called cervicogenic vertigo. And what we see for a lot of these patients, it's not the true world spinning kind of dizziness. It's this internalized sensation of dizziness. So again, the terms used to be more vertiginous in nature, but what we've seen in the literature now is that it's mostly an internalized sensation. It is not directly related to BPPV, Meniere's, neuritis, or any central pathologies. As we'll see from this, right, it's coming from the neck. How we get to that answer, that's a little bit tougher of a question. We don't really have good etiology behind it. What we know most of the time, though, is from emergency departments. Someone has an accident, a head injury, concussion, motor vehicle accident, and they're coming in with neck pain, right? That's one of the criteria, and they're having dizziness in their head and neck. Now, that does not mean they cannot have BPPV from hitting their head or having a concussion. We're going to separate those two out, right? Some of the thoughts behind this is that it might be related to inflammation, degenerative changes in the cervical spine, so like degenerative joint disease, degenerative disc disease, or it could just be muscular in origin. So the characteristics of what patients might complain of are reports of dizziness, including imbalance, unsteadiness, disorientation. A key indicator, though, is they need to have neck pain with it. They're most likely going to have cervical range of motion limitations. Most of the time, it's in rotation that they're limited, followed by extension and flexion. And then they might also have a concomitant headache, which makes sense if they had a head injury or concussion. So some of the theories right behind this, the top theory is that it's this proprioception issue. The neck is no longer communicating with the inner ear, which isn't really doing a good job communicating with the eyes. And then all of them are not communicating very well with the brain, right? It's particularly the cerebellum. Again, in the 50s, Furman and Cass, this used to be called the Barré-Luo syndrome, a neurovascular claudication, essentially. That blood flow was being impeded from the anterior inferior cerebellar artery, and that was causing suffocation of the inner ear vestibular mechanism, causing dizziness, dysarthria, all like our 5 Ds and 3 Ns. That's kind of been pushed away over the past 15 years. And really over the past 7 years, more and more research has come out looking at, okay, you know what? Maybe this is proprioception issue. Maybe the mechanoreceptors in our neck aren't really communicating very well via our cervico-ocular reflex and cervicocolic reflex. Maybe they're not really communicating very well with the ear and the eyes and then finally to the relay center in the brain. There might also be, because there's neck pain related to this, pain signals that are affecting the vestibular nucleus. Again, giving them this mismatch of information. There are some articles looking at potential migrainous relationships, particularly looking at like vascular trigeminal pathways, especially when the neck is in pain and there's inflammation in the area. So again, what we see is because of pain, because of guarding, particularly from a fall or head injury like a motor vehicle accident, the muscles naturally want to splint around our neck, right? So they'll splint up, they'll get tight. That tightness decreases range of motion, and it causes this abnormal input, again, from the neck, particularly SCM, scalenes, upper trap, even our suboccipital muscles. And it creates this pattern where we don't want to move. We have poor stimulation of our vestibular system from our cervical spine. And then we get dizzy when we turn our head, so we still don't turn our head further. So you can see here, it's this little pain spasm pain cycle that's happening, that we're in pain, we don't move our neck, we get dizzy, but we get dizzy when we move our neck, so we don't move our neck. So it's very cyclical in nature. So we have to find a way to break that cycle. Of course, as I mentioned, since we're working mostly with physicians, ENT, otolaryngologists, what we're looking at is how do we differentially diagnose it? From a physical therapist, physiotherapist standpoint, we don't have technology, right? So I have to listen to the patient subjectively and come up with an idea. Hopefully they've been seen by an ENT, audiologist, a neurologist, somebody. But my competing hypotheses are always going to be looking at BPPV being a potential marker, peripheral vestibulopathy, any type of like migraine related vertigo, particularly MARD, so migraine anxiety related dizziness, especially if they had a head injury or a motor vehicle accident, there's going to be anxiety behind that. And of course, I must always rule out central pathologies. The hardest part is right here. There's no gold standard for diagnosis for cervicogenic dizziness. There's no imaging, there's no blood test, there's no VNG, rotary chair, nothing. Can't do ABRs, nothing. Nothing's going to tell us if it's cervicogenic in nature. So pretty much our jobs are to rule out everything else and then go to this almost diagnosis of exclusion. The most consistent diagnostic criteria is co-concurrence of neck pain and dizziness in the absence of any other possible cause for dizziness. So for me, I'll do my bedside evaluation. I'll look for BPPV, double check on any red flags, and then go on to treating for cervicogenic dizziness. Because, right, we could look at a vascular cause, as I already pushed away. The theories aren't really strong for vascular. It could be neural, and the one we're really looking at is proprioception. And so we see under proprioception, it could be whiplash-associated disorder, which is this umbrella term following a head injury from a car accident. But it also could just be general degenerative changes, age-related changes in the neck, spine, and the muscles related to that. Again, the symptoms are pretty present here. Sometimes they might even have like this feeling like they're going to fall. And a lot of times this comes from the muscular spasms and that decreased motion. It is a high specificity in terms of our testing that neck pain needs to be present. Lower on the list, vomiting, tinnitus, palpitations. Those are, again, low on the list, but once you start seeing those, I'm probably pushing more towards a differential diagnosis. Those are pretty rare. Objectively speaking, what I'm going to do as a PT, first off, I'm going to check range of motion after all red flags have been cleared. So they're turning their head to the right, turning their head to the left, and that brings on symptoms, not just pain, but also dizziness. And they probably have a decreased range of motion, whereas 80 to 90 degrees would be full range of motion. They might only have 30, 45 degrees motion and not that much, and they get dizzy. Another test that can be ran is what's called the joint position error testing. So a laser pointer is on their head, and we're looking to see, do they have the proprioception to close their eyes, turn their head, and bring their head back to where the starting point is? Again, it's our general test for proprioception. and it tells us if the muscle spindle fibers in the neck are relaying the information correctly. So this has some pretty good research behind it. Same thing, we can look at posturography, looking at the Romberg test, looking for any type of postural sway with the patient. And then, of course, we need to do our bedside evaluation that Richard Gans always talks about, looking at our head thrust test or head impulse test, whichever you want to call it, looking at our post-head shake nystagmus, looking at our gaze evoked nystagmus testing, and then, of course, our posture tests. As we go a little bit further into cervical testing, we have two tests that kind of pair well with one another, the cervical torsion test and the smooth pursuit neck torsion test. And I say that because of the reflex arcs that are coming from the neck to the vestibular and ocular system, that's going to be our cervical ocular reflex and cervicocolic reflex. Those are both tested by having the patient keep their eyes on a target and turn their head. Now, when I do that, that's our traditional VOR exercise. As I turn my head, I'm getting dizzy. I don't know what's causing it though. Is it me mechanically turning my neck? Or is it the fact that I'm activating my vestibular system through endolymphatic fluid motion, and that's stimulating my vestibular? So we have to pull away from vestibular. And the best way we do that is by stabilizing the head. I'm on a stool right now, stabilizing the head and then having the body rotate. There's no fluid motion in my inner ear. Vestibular system should be relatively inactive. So in this position, my head is still turned, but the gyroscope in my ears did not move. So theoretically, it's my neck moving. And if I have pain, dizziness associated with it, it's most likely coming from my neck and not my inner ear. And then the smooth pursuit neck torsion test is the same position, but then they check smooth pursuits in this neck torsion position. And that sometimes can look like this. So the patient's head is in a torsion position, and we can see some jagged pursuits as she's following my finger. Her neck is in a torsion position. And that would be a positive, abnormal, smooth pursuit. Also, we would be checking out the cervical spine. Looks a little laggy right now. We'd be looking at the cervical spine to see if palpating the cervical spine brings on any of these symptoms. Next on the list would be cervicogenic dizziness testing. So as I mentioned, these were the tests with some pictures behind them. Can y'all hear me? Everything is being very laggy right now. Okay, there we go. That's better. Let's see. All right, so for the algorithm, when looking at what do we do with these patients, we can see as we go through this stepwise progression, I'm going to be more focusing on the PT intervention on this side. Obviously, for triage, we want to look for those red flags for any fractures, referring for imaging, referring for further vestibular testing. But on my end, from a PT perspective, I have to look at the vestibular system and I need to look at the cervical spine. We have those special tests that I talked about, the neck torsion test, relocation, the kinesthetic senses, the joint position one that I was talking about. I would be remiss if I didn't talk about pharmacological intervention. They're pretty straightforward, right? Muscle relaxers and NSAIDs are going to be best for relaxing the muscles, especially if we're thinking about that pain, spasm, pain cycle from before. And then if they're experiencing any type of MARD or vestibular migraines, sometimes TCAs can help. Even if you were to like throw in like nortriptyline, amitriptyline, Jeff Staub looked at for 3PD, looked at adding in like a rescue Xanax, can also help with some of these patients. But that's outside of my scope of practice. I don't deal with pharmacological management. I'm not a physician. What I can do is use my hands to assess and use my hands to treat these patients. So from a manual therapy side, what we know is moving the joint, moving the muscles, moving the body is what helps the best. And so we can do graded mobilizations to this target segment. Now, I want to make mention this target segment. Most of the research looks at C1 and C2 as being the primary areas for where most of our cervical proprioception and input is going. All right, so everything is getting very slow for me right now. It's me or what? All right, so from a manual therapy side, there we go, I think we're back on. From a manual therapy side, right, we have two options. We can do manipulative therapy to the upper cervical spine, if indicated, both from a rotational component and a side flexion component. Both have been demonstrated to provide really good relief for patients, reduce pain, improve mobility. And remember, those were the top two reasons for that pain, spasm, pain cycle. So if we can improve movement through hands-on manual therapy intervention, better. In the States, we do what's called trigger point dry needling. It's very similar or akin to acupuncture, except the needle penetrates through the skin into the muscle, and it creates a local descending pain pathway, again, relaxing the muscles. So the whole purpose behind manual therapy is to improve mobility, reduce pain. And if we can reduce pain and improve mobility, cervicogenic dizziness tends to clear itself up pretty fast. But outside of that, the next best step is exercise. And again, that exercise looks like what we were just talking about. That's that, let me see if this does not slow me down again. Go full screen. Most of the research is looking at cervical range of motion, proprioception, getting the head and neck moving the way that it should be. So one of the exercises is called a towel snag. It's a Brian Mulligan maneuver. All it is where they're moving the towel, it's mobilizing the neck the same way I was doing it with my hands. The patient's doing it with a towel. And of course, VOR exercises, even though they have no vestibular hypofunction, what do we know to be true with the VOR? If my head and neck is looking at a target and I'm turning my head, I'm getting range of motion, I'm getting smooth pursuit, I'm getting target tracking, especially as you add in VOR times 2. So you're hitting all components of the cervico-ocular reflex, cervical spinal reflex, and cervico-colic reflex. So all of those cervical reflex pathways are hit when you looked at VOR exercises, mobilization exercises, and then of course, nice and easy stuff, some stretching of the neck, side flexion stretching, rotation stretching. There's a lot. But most of our patients, they're in that acute phase where it just takes some time. I don't know why everything is slowing down. I apologize. So last little bit on here. So multidisciplinary approach is best, right? That's the best way we can go through this. Pharmacological management has its place, as I mentioned, right? For reducing pain, reducing muscle spasms, getting them out of this like fear avoidance pathway, again, so they don't have abnormal coping mechanisms. Cognitive behavioral therapy can help from a psychology standpoint. But our biggest one, right, has to be accurate diagnosis again, ruling out for vestibular complaints. And that comes from solid ENTs, audiologists, and neurologists who have neurodiagnostic equipment, who have training like Dr. Neha does and everyone else who's participating in this, right? If you've never worked with vestibular patients, this is the first step. And this first step through American Institute of Balance India will help you be better ENTs, neurologists, audiologists, physios, because you need that differential diagnosis. If you don't do the differential diagnosis, if you don't do your kinetic rotary chair, your VNG testing, you're missing out on potential diagnoses. And if they fit the criteria for cervicogenic dizziness, please find a physiotherapist who works with their hands, right? Does hands-on therapy. Because hands-on therapy, manual therapy with exercise has some of the best research for cervicogenic dizziness and can really help push these patients to the next level, getting them better. Because what happens is if this test is negative, this test is negative, and this test is negative, these patients are going to go back home with no answer, and they're still going to be in pain and have dizziness. So please just look at all the potentials and then realize that the neck can be playing a role in dizziness that a patient has. So really passionate about this stuff. I think it's great because it is a diagnosis that can't be easily diagnosed. And so it makes it fun because we have to really look at every potential avenue that's causing these patient symptoms. But thank you very much. I appreciate it, and I'll stick around for the panel.
Thank you, Dr. Steven, for an excellent session on cervicogenic vertigo, because a very common thing that we all come across in our practice. So thank you so much, and I request you to please wait for the panel discussion. Yeah. Okay, so I'm still live. What I would do is let us go through my session today for labyrinthine concussion. So Vinayak, is my sharing on?
Yeah, not yet, ma'am.
Yeah, please start my sharing, and you can just play down my slides. Yeah. Okay, so everybody knows me probably because I'm the director for AIB India, and I'm the consultant neurotologist, vertigo and ENT specialist practicing at RTKL Vertigo and ENT Clinic. I am a member of Barani Society, yes, and associate member of International Headache Society and BAAP. So our motto and idea was just to keep on conducting more and more idea of taking the vestibular medicine ahead and to train all the doctors in all parts of India and probably the world with our vertigo practices and spreading the word and spreading the knowledge. So with this, I would request that please start my sharing.
Yes, ma'am, you can share your screen.
Fine. Please guide me if I'm going right or not. Yes. Okay. Visible?
Yes, ma'am.
Okay, so we're good to go. So today I'm going to talk about labyrinthine concussion, a very lesser known topic and something which is always in forgotten or maybe diagnosed as a secondary BPPV among the doctors, especially because there's a very lack of knowledge about this particular diagnosis or the condition. So we all know that our labyrinth is basically divided into a membranous labyrinth and a bony labyrinth. So we all speak more about bony labyrinth considering it is a BPPV or a positional vertigo. But there's something known as concussion which occurs post a head trauma, and concussions are mainly divided into a cortical concussion which affects the entire brain, or maybe a part of it getting attached with the labyrinthine, or only the labyrinthine getting affected in the entire scenario. So what basically happens? There is a structural or a metabolic disturbance to the CNS following an impact, any injury over the head. And this you will not be able to capture on any of the imagings. Basically, it's a more of a diagnosis of exclusion, because mainly it's caused because secondary to the head injury. So what happens is there is a cutoff of the blood supply there, and there is increase in the energy demand. So just to again go back, traumatic injury to the inner ear, which leads to vestibular or the auditory dysfunction without the structural or a damage on the imaging. There will be a history of head trauma, and there will be sudden acceleration and deceleration forces which will affect the labyrinth, the semicircular canals, and cochlea. So the pathophysiology says that the brain is gelatinous in material. So only when it is when it gets affected or when we die, it is in the frozen section that we actually see the picture of the brain. But actually, it is gelatinous, which has the white and the gray matter. There is a free floating cerebrospinal fluid in that, and there is no shock absorber in this in the brain or in the even in the membranous labyrinth. So the rate of movement by which the fluid or the gelatinous material is moving, it is having a different rate of movement inside the skull, and there is a complex neural network which can cause a microstructural damage or the increase in the energy demand and the reduced blood flow throughout the brain. So basically what happens, it follows a coup and a counter coup injury. So basically if the injury is happening on this particular side, the brain will the gelatinous matter will shift on the other side, and again there will be a reciprocal effect coming in the between, and which follows the Newton's third law of motion, which says to every action there is equal and opposite reaction. So I'll just show a video which following this that will tell you about more about the symptoms. So what are the symptoms we have? There is more of vertigo. It's a very the giddiness is very strong suddenly against starts after the injury. There is imbalance and there is unsteadiness. It is generally severe in nature. There will be hearing loss, may or may not be, but you need to evaluate the patient even for tinnitus. There will be space motion discomfort. The patient may develop psychological problems, maybe a post-traumatic stress disorder, and it can be polyimpact syndrome if it is an multiple affected parts in the body. So basically, the history of head trauma is very important. So the history, the patient will give you an history of head trauma. There will be the entire battery of investigation, like the vestibular evaluation should be carried out. You should always examine the eardrum, look for a congested TM or a hemotemphanum, look for your normal routine tuning fork test, and then post the patient when the patient is in the condition and not very severe to undergo the process of vestibular evaluation. Please do an audiogram of the patient, which is important. Impedance only if it permits or it is possible for the test to happen. HRCT temporal bone and MRI are the other tests like the CT brain, which can be performed in this. So generally the management includes, the management has more of vestibular rehabilitation therapy, which has more of the effect on the patient, and more the patient comes back on its foot to walk and have the normal routine activities. Vestibular suppressants are the mainstay of treatment, wherein for the first initial days, you should always give a suppressant and avoid giving any stimulant. For example, prochlorperazines, cenarizines, and meclizines are more effective in such conditions. If the patient develops any kind of psychological state, you can always go for a cognitive behavioral therapy and audiological treatment in case if the patient presents with tinnitus or there is a requirement of tinnitus masking therapy, you can go with the audiological treatment of the cases. So when we talk about vestibular rehabilitation, so what are we basically looking at? For vestibular rehabilitation, we are looking for the vestibular compensation. Generally in rehabilitation, we say there are 3-4 points. One is non-stabilized, stabilized, uncompensated, compensated. So basically you need to adjust where the patient is at this point of time. They may be unstabilized, getting treated with medication, stabilized, they are back on their feet, but still they get dizziness, and they may be uncompensated, and then the vestibular compensation will happen if the right vestibular rehab is given to the patient. Utilization of the brain plasticity. See, the brain adapts very fast to the situations where they are. So if they keep on seeing a particular condition for a very long time, the dizziness will keep on increasing, and there will be neuroplasticity which is set up. Only with constant rehabilitation measures, you will be able to break the plasticity of that brain, and that is very much required. So for the cognitive processes, yes, especially in the geriatric population, we like to have the reasoning, question answering, identification of the date, time, place, so that the cognition and the reasoning effective systems are also part of the rehab system. sensory inputs, strengthening of the muscles, and a lot of dedication and motivation. The patient and doctor trust should be built up so that there is a lot of motivation in the patient to get through this illness. So basically in the vestibular rehabilitation, we always follow an hybrid approach. Basically, it consists of the adaptation exercises which are there to improve your vestibular ocular reflexes, habituation along with the stabilization and the posterior reflexes where the habituation happens, and substitution with the effective methods on the proprioception so that all the 5 organs which maintain the balance like the brain, spine, foot, eyes and ears, they come together and we get a very good result or the very good outcome of the vestibular rehab. So adaptation exercises, so basically adaptation are very simple exercises. For example, you can take maybe 2 cards. Now here I've taken 2 cards like this, and you can ask the patient to be in the, just have a look at one point in the card, X, Y and Z axis. So basically it's a very simple exercises wherein the patient can have, and on all the 3 vertical planes, they can have a look and they can maintain the saccadic movements of the eyeballs. In smooth movements, you can take 2 placards wherein the words or the sentences are mentioned, and the patient can just read from one way to the other way so that they maintain the smooth pursuit while doing so. In focusing while turning head, the patient can take a pen in their hand and just move their head right and left. That will be the VOR1. And VOR2, they can just move the pen and the head will move in the opposite direction. That will be VOR2. So such is the adaptation exercises. I've just shown 4 of them because these are the basic terrain that you should always start with any of the rehab system which is effective to the patient. And if you don't fix the eyes, the entire movement will never get fixed. So you should always start with the adaptation exercises. So next comes the habituation. Habituation is all about the standard head, horizontal head movements, up and down head movements and the sideways, and gait with head turns. So you can ask the patient to walk straight and turn the head so that the compensatory mechanism works well. And habituation and adaptation exercises can also be given as an homemade exercises because only they can do it at home if you have a good recorded videos, and they can ask them to do it regularly for a period of 3 weeks so that they set in very well and you get a very good outcome, as at least the reflexes get involved and the head and neck improves movement. Substitution exercises we generally recommended to our to the physiotherapists because they require a physio ball or trampoline and a very guided method so that there is an assistance given so that there is a static and the dynamic movement both on the for the patient, and they are very confident while doing so because it works on the proprioceptions of the body. So the entire balance system comes into the function while doing these exercises. So the recovery and the prognosis is generally within weeks to months. So early diagnosis and treatment gives us a better outcome, and sometimes you require a multidisciplinary approach in such cases. Maybe an ENT will be working with a neurologist along with your audiologist colleague to deal with the tinnitus. So keep it with open arms and you should be ready for that multidisciplinary and a good partnership between the doctors to treat the patient and make a good team for the comprehensive management of such cases. So the take-home message is brain cannot fix what it cannot see. So no movement means there will be never an improvement. Focus and concentration will always make it better. And cognition is a very important tool in vestibular rehabilitation therapy. So thank you so much. Thank you. Okay, so we can now, I would request all my guest speakers to please come online so that we can start with the question answer and the panel discussions. So Dr. Kavita and Dr. Prashant, yeah.
Yes, I'm there. Good.
Yeah. Okay. So now some questions. Now there was one question which says, they're asking that to Dr. Kavita. Is Dr. Kavita around? Okay, so maybe we'll go back to. So what is the? So we'll go with the other question then when she joins back. Say, is the lifestyle changes associated with the etiology of vertigo, and can lifestyle modification reduce its prevalence? So
In
I just
what
asked it,
Meniere?
no, they
In
have
Meniere?
just, it's a general terminology for vertigo
Yeah.
that I have asked for. So I would suggest that yes, lifestyle changes are much required in both Meniere's and migraine, because you need to have a reduced salt intake. You need to reduce on the caffeine and the alcohol and the fermented foods. So that all is pretty important. And even the mobile phone or the screen usage should come down. While you, and we must increase the magnesium in our diet, because it's found to have some researches, you know. Uh, Sir, you will have to add on anything on this, and Dr. Stephen, even you can add on this point. Lifestyle modifications associated with vertigo, or maybe specifically for migraine and menias.
Yeah, appropriately said, Neha. Nowadays, screen time, caffeine, alcohol, all these are more factors which are giving migraine, Meniere's complex, and so many disorders. Magnesium, yes. Now, I am trying to do even the study where we are doing serum magnesium level in on our migraine patients, and there are some results which are showing that there is a decreased level of magnesium, and I'm adding MGD3 for them. So it is good result with the magnesium.
Okay. Dr. Stephen, you want to add anything on this? Yeah.
Yeah. So even though I'm not running labs, what I'll have patients do, especially for you are who are trying to figure out what's causing the triggers, is I have them take notes. So even like a note on their phone or like a journal. So every time they start to have these dizzy spells and they don't know what's causing it, write down what they were doing before the dizzy spell, what they ate. Again, just trying to figure out every little thing to figure out these triggers, both for like traditional migraines, but also vestibular migraines. It's all about finding the triggers, like you all are saying, looking at blood work, but sometimes they don't even know what those triggers are. And so just bringing it to light for them to just write down what they were doing before or during, or even what helps their migraines, can help kind of set them up for success.
Okay. Dr. Kavita, there is a question for you, that why was clonazepam started in one of the cases that you represented? I think they were asking that why did you start with clonazepam?
So a lot of patients who are in the Meniere's migraine spectrum, they do well with clonazepam and escitalopram combination. And that was the reason that was started. And some amount of it helps to elevate some amount of anxiety and, all those symptoms that are there in those patients.
Okay. So the next question is, please, okay, now should I continue with in your experience, sir? This question I think you will have to answer, that what patient number of percentage of patients of Meniere's disease require surgery?
So to answer that question, say around 10 to 20%,
Okay.
because most of them are coming in early stage. We can manage on our medical management. They are doing well, and we ask them to do a serial audiometry and come back in follow up. And if they have any episode, they will come back. Because when the new episode, suppose the patient is in early stage with the steroid, with the diuretic, with the Dimox, everything is settling down. And if the next episode comes, patient again comes to you early, again we can start. So we can prolong that SN loss and other severity of his dizziness. But yes, if the patient is coming in late stage, mid stage, then you may have to undergo surgery. So around say 10 to 20% people
Okay.
require surgical.
And now they're asking that what are the duration that the diuretic should be given, and which class of diuretic would you like to take? I mean, which
So
you
I
would.
give furosemide and in a decreasing. So I give start with the steroids and furosemide combination for say around 7 days. Then next 7 days decrease dose and next 7 days decrease dose, and make it half, half, half. And then after that they are not no longer on steroid or even diuretics.
Okay. Okay. Acha, and there is a question which they want to know about the diagnosis of the Meniere's migraine overlap syndrome. Dr. Kavita, you can highlight some points on this Meniere migraine spectrum. Basically, they want to know about this. Yeah.
So any patient who has complaints of Meniere's disease, now if they have those typical issues of having tinnitus along with hearing loss and giddiness, and you put them under the Meniere's category, you can always rule out if they have any triggers. They have some amount of photophobia, phonophobia, or if they had a history of migraine previously, if they've had history of heaviness in their head, or just sometimes if they're moving their head and they sometimes have some giddiness, or if patients of Meniere's disease also have some amount of BPPV along with it, then I would put them in the spectrum of Meniere's migraine.
Okay, sir, you would like to highlight anything on this Meniere's migraine?
Yeah, see, I always say that for the patient, his episode may be from BPPV. The same patient can have migraine also, and the same patient can have Meniere's disease. So whatever his dizziness, when he come to explain you, Just don't categorize, oh, he's a Meniere's patient. No. At that point, what the patient complains and where he falls. So we have to understand that there could be a complex people who are maybe having two, three types of vertigo coming in that same patient, and we have to analyze and try and treat accordingly. So yes, we have to see all those features and ask every time what is his dizziness, what are the episode, what are the triggers, and how was his episode. That will give you elaborate. So history is the only thing which is going to guide you whether this vertigo is now Meniere's or BPPV or migraine, whatever.
Dr. Stephen, you would like to add anything on this? Yeah.
Yeah, I'd have to agree with everything he was just mentioning, because you have to listen to the patient and the symptoms that they have, because these are not mutually exclusive diagnoses, right? So you were even talking about concussions. We know that patients with concussions who have a history of migraines can have an elevation of migrainous symptoms because of that neurometabolic cascade that's occurring. So your job, our job, everyone's job is to figure out what is causing this dizziness and what's the best form of treatment, right? Are you giving your diuretics because of one thing, or are you having to deal with this from a vestibular management? But in reality, we don't really get one clear-cut patient. Like he was mentioning, they might have multiple diagnoses that all have some kind of play in dizziness, and you have to just be a really diligent clinician to listen to the patient and treat them appropriately, and then realize, okay, one symptom might clear up, but now another symptom shows up. So it's not just here's some drugs, leave my office, I'll see you in 3 months. It's good continuous follow-up, because you clear up one thing, especially for concussions, another thing might appear.
Okay. The next question is, when do you start a rehab in cases of BPPV, and what preventive measure do you advise with patients with recurrent BPPV? So basically, ideally, rehab is not required in patients of BPPV unless they have been misdiagnosed and the duration has increased such that there has been a vestibular hyperfunctioning also because of the drugs that they have taken in the span of time. So unless and either if you're first to make the patient free of the medicines and then test them for BPPV, do the canalith repositioning maneuvers, and only if you find a deficit and their imbalances, then only I think there is a role of rehab coming up. Or else the canalith repositioning maneuvers do the job very well. And in cases of recurrent BPPV, we always ask the patient to maintain their vitamin D levels and the magnesium levels so that the stability is maintained, and also look out for any other overlapping symptoms with BPPV that can be the cause. Dr. Kavita, Dr. Prashant, and Dr. Steven, you want to add anything on this?
No, no, very well said.
Yeah, yeah, that was good. One thing I would say, while traditional vestibular rehab is not needed for BPPV, like you mentioned, Dr. Neha, patients with chronic BPPV, this is where some of the anecdotal evidence comes into play, that someone who's had BPPV for months at a time is not moving their head and neck. And so even if 1 to 2 weeks of physio might be good just to get their neck moving again after repositioning treatment, right? Because we've all probably seen this. You clear a patient of BPPV, they sit up and they're still turning their body and not turning their neck because they're fearful of getting dizzy. So even if it's just BPPV, rehab is good just to get their head and neck moving and get them out of that fear. Again, only like probably 1 or 2 weeks is all you need, because what happens is the longer they go without moving their neck, the higher likelihood you start getting cervicogenic dizziness, right? So yeah, I would agree. BPPV really isn't necessary for having rehab, but if they have any also other balance issues that might have been masked because of the world spinning vertigo, a few weeks of physio is probably not a bad thing. It can help with their head and neck and just help them get their balance right back to where they feel like they're at.
Dr. Kavita, you want to add anything on this?
No, I think they've covered everything. Also, post maneuver, I do ask them to lie down at an angle of 45 degrees and especially prevent looking up, and also prevent turning to the side in which the BPPV has occurred. It's better to sleep straight, and if they need to turn, then it would be to the opposite side.
Okay. So now there's a common question, that is vestibular migraine a diagnosis of exclusion? So that this is a very well, there's no evidence, because basically if you see in Barani societies, all criteria, they say nothing else is found. In other words, the point number D always says it says a diagnosis of exclusion even for a BPPV. Does not fit with any other condition. So basically, it's not like that just because the headache criteria has been removed by vestibular migraine. But yes, you need to dig onto the more and more history, because when we basically divide vertigo, it's more of a central vertigo, peripheral, a psychogenic form of vertigo, maybe just a systemic illness which can be preceding the symptoms, or a drug-induced vestibulopathy. So you need to dig into the history basically to label that patient as vestibular migraine. Easy terminology to put it on any face value, but there can be something more or something less to that also. So it's not a diagnosis of exclusion. There will be a history of phonophobia, photophobia, but then you need to go deep into diagnosis and take a longer duration of history, maybe 20-25 minutes to assess, and then assess the patient and keep a follow-up if you have any doubts. So you want to add anything on this, Dr. Kavita?
Yeah, Neha, in that, see, in the all that migraine patients, when you do BNG, you
Hmm.
see erratic patterns.
Hmm.
You see saccades which are abnormal, the smooth pursuit abnormal. You will get all the BPPV like picture there. So when everything is cluttered, which is not falling, then I feel that is what is migraine. Why? Because it is happening at that level where third, fourth, sixth nuclei, and that their irritability is there, and therefore when you do all this on VNG, definitely there will be some evidences on the VNG. Other than that, there are no other evidences.
Dr. Kavita and Dr. Steven, you can also add on to this. Yeah.
Yeah, no, I agree that we will find some amount of evidence either on history or on VNG, like Sir said. And often we are doing a lot of migraine patients together where we are getting, smooth pursuit has some catch-up saccades, or your random saccades have some saccadic events. So definitely you do get some signs.
Okay. And Dr.
Also,
Steven,
one more, Neha, there is a like pupillary hiccup. So even that is on pupillometry you can see that
okay.
normally when you flash a light, the pupil will get constricted, but it will not dilate. But in these patients, sometimes you'll that dancing pupil. So that is what you get in pupillometry. Even nowadays, I am finding it, and it is there.
Okay. Dr. Steven, you want to add anything on this?
I think they hit most on the diagnostic and the whole, is it a diagnosis of exclusion or not? Again, I'd always go back to taking a good, strong subjective exam with patients while utilizing the objective, because you're ruling out other potential causes.
Okay. So there is one, there are two more questions. How long would you like to give vitamin D and magnesium?
6 weeks max.
Yeah, 6 to 8 weeks. But of course, always measure the vitamin D levels, because you may never know if they're taking already a calcium supplement, which may be having magnesium. So just check it and then give it accordingly. So six
Yes.
to eight weeks is max that we would like to give. And magnesium, you have various preparations that also can be given. Dr. Kavita, you want to add anything on this?
No, I think we should measure the levels at frequent intervals to determine if we are not overdosing them.
Okay, fine. And the last question for the day. What anti-migraine medication do you prefer and why? So basically, now to answer this question, it depends upon the patient's profile. When you take the history as to what patient is having, suppose if there's a patient with hypertension, we will prefer taking propranolol. If there's a patient coming with anxiety, we will have prefer more of amitriptylines in this way. So basically, the type of, there are only 6 anti-migraines that we are well aware of, that comprises of propranolol, plinarizins, amitriptylines, SNRIs, then divalproex and topiramate. So based on the body composition, suppose the patient is overweight, then you can give. But again, there's side effects on the eye. So that all things have to be kept in the mind when you give the anti-migraine medication. But only anti-migraine isolated will not help, but it will require lifestyle and dietary modifications too. So Dr. Kavita, Dr. Prashant, and Dr. Steven can also add on to this.
Yeah, it's all the patient profile where to look at. I mean, all that thing is not decided how the patient is, and then only we decide. Because yes, sometimes we feel flunarizine worked well, but then patient gets severe drowsiness. I mean, they feel that it gives drowsiness, and they don't want to be there on the flunarizine. And we can shift it to topiramide. They are much better. The results are good. We should give it at least for 3 months, and then as a pulse therapy, we should pursue that migraine. And mainly this trigger management. If the triggers are well controlled, they don't need any even pulse therapy.
Okay. Dr. Kavita, you want to add anything on this?
Yeah, agreed. In very mild form of migraine patients where the frequency is not as much or the intensity is not as much, even just plain magnesium also works very well along with coenzyme Q. And younger patient females in the reproductive age group, I prefer to go with amitriptylines. For older patients, again females, I go for divalproate in the older age group. And again, when you're giving propranolol, rule out they're not asthmatic. If there is some amount of anxiety, like I mentioned, I also do add in some amount of clonazepam. So it is very patient related.
Dr. Stephen, you want to add anything on this?
Yeah, so again, when looking at like the migraines, sometimes for vestibular migraineurs, the traditional like sumatriptans, rizatriptans, even like your antiemetics for some of the symptoms that the patients might be feeling usually have helped. I've seen a lot going back from like Jeff Staub's article in 2018, looking at like 3PD and some of these more central patterns of dizziness and vertigo. Even like your SSRIs, amitriptyline, nortriptyline have been pretty good. I've seen some pretty good research looking at CGRP blockers and Botox, and a lot of my patients have had pretty good results with Botox injections as well, especially looking at that neurogenic like claudication from the signals from the migraines. But again, PTs in the States, and I'm presuming also in other countries, cannot prescribe medicine. That's why I leave that up to you all, the physicians, to do that. I just deal with the after effects with the patients and see usually what works pretty well with them, especially when managing the therapy afterwards. Because you can put all the drugs you want on them, but if they can't do any rehab because they're nauseous, because they're dizzy, that's where good communication between physicians and between the physios is really needed, so we can communicate back and forth to see how we can best help the patients. But I think you hit the nail on the head, right? We got to look at the triggers, and if you can manage the triggers, you can manage a lot of stuff without pharmacology.
So that means you require a multidisciplinary approach when you deal with cases of vertigo, and you should be very open to work with a neurologist, an audiologist, and the physiotherapist around, so that the patient gets treated.
And the psychiatrist also.
Yeah, and probably psychiatrist if the conditions just go beyond the levels of, the drugs. So with this, thank you so much to Dr. Prashant Keble sir, Dr. Kavita, and Dr. Steven Spring joining right in the morning on Saturday morning from USA, straight up. We are thankful to all the participants and the distinguished speakers and my team at Doc Mode and team at AIB India, of course, who made this program a great success. And we are having more than 1,000 doctors who are viewing this program. Probably we have more numbers after this when we count back after the session gets over. And we look forward to having you back on this session again on 25th, 4th of January, which is again 2026, which is again a 5 p.m. IST, which is on a Saturday. And we look to continue our advancement and our motto and objective to spread education in vestibular and balance sciences in India and all parts of the world. So thank you so much from my end to everyone. Over to you, Pinakin sir, for some closing remarks.
I think you covered everything. So it is 25th January and 7th of March.
Yeah, 26th January and 7th of March.
Yeah, so we have already lined up the next set of webinars, and we would be glad to see you people for the webinar for an interesting session like today. I thank all the speakers today. We had a wonderful session, a very interesting session. Thank you very much.
Thank you.
Thank you so much. Thank you.
Thank you very much.
Thank you.
Have everyone a good day.
Same to you.